जशन मैम प्लीज स्टार्ट कीजिए, चालू हुआ।
Good afternoon, everyone. Myself, Jashanpreet Kaur, Assistant Professor at Amar Shahid Baba Ajit Singh Jujar Singh Memorial College of Pharmacy, Bela. It is my great pleasure to welcome all the respected dignitaries, speakers, faculty members, and dear students to this online national seminar on antimicrobial resistance, a silent global pandemic. On behalf of our institution, I warmly welcome all the participants who have joined us today. Now, I would like to give a brief introduction of our institution. Amar Shahid Baba Ajit Singh Jujar Singh Memorial College of Pharmacy, Bela, is one of the premier pharmacy institutes in the northern region. The institute was established in 1993 in the memory of Sahibzadas Ajit Singh Ji and Jujar Singh Ji, the elder sons of Guru Gobind Singh Ji. Over the years, our college has made significant progress in providing quality education and research in pharmaceutical sciences. The institute offers various programs such as Diploma in Pharmacy, Bachelor in Pharmacy, Master in Pharmacy, in Pharmaceutics, Pharmaceutical Chemistry and Pharmacology, MSc Pharmaceutical Chemistry, and Bachelor in Medical Laboratory Science. The college is affiliated with IKG Punjab Technical University Jalandhar and is also recognized as PhD Research Center in Pharmaceutical Sciences. A part of NBA accreditation recognized under UGC 2F Act, it occupies 56th place in NIRF 2021 ranking and come under platinum category by AACTE C2 2018, 2019 and 2020 survey. Now, coming to today's seminar, this seminar focuses on antimicrobial resistance, which is considered one of the most serious global public health challenges today. The misuse and overuse of antimicrobials in humans, animals, and agriculture have led to the emergence of resistant microorganisms, commonly known as superbugs. Through this seminar, participants will gain knowledge about the mechanisms of antimicrobial resistance, common multi-drug resistant pathogens, and the impact of AMR on global health. The seminar will also emphasize the importance of rational prescribing practices, infection prevention measures such as hand hygiene and vaccination, and the One Health approach connecting human, animal, and environmental health. I am sure that this seminar will provide valuable insights and enhance awareness about responsible antimicrobial use among healthcare professionals and students. Now, it is my great honor and privilege to extend a warm welcome to our respected chairperson, Dr. Manju Rawat Singh Ma'am, chairperson of IPGA Women's Forum. Ma'am, your remarkable contribution to pharmaceutical education and your continuous efforts in empowering women pharmacists are truly commendable and inspiring for all of us. On behalf of Amar Shahid Baba Ajit Singh Jujar Singh Memorial College of Pharmacy, Bela, I extend my heartfelt welcome to you, ma'am. We are truly grateful for your presence.
Thank you, Dr. Jashanpreet. Am I audible?
Yes, ma'am.
Namaskar and warm good afternoon to all of you. It's always wonderful to be connected, especially I must congratulate the main organizer of this program, Dr. Shailesh, then the core team, that is Dr. Neelam. Dr. Geeta is also very close to me. These people are doing wonderful job if you talk about IPGA Women Forum, be it at North, South. So it's really wonderful to see these wonderful ladies doing so, working together towards a profession, our profession. So I really appreciate it and I must congratulate all of you. The topic selected is really very, it's really needed because when we talk about the antimicrobial resistance, this is really coming up as a major health problem if we talk about the 21st century, because, if this will persist, what is going to happen is like the infections which were so common back days, they will become a major health problem if this antimicrobial resistance will come into play. So there is really a need to the need of regulation of the so many avenues which are required, be it at the front of a health professional, be it a pharmacist, be it at the government front, because the antibiotics, the ease with which these antibiotics are available to everyone, that is the major issue, because of which this is really turning out to be a great pandemic. Because when we talk about the basic problems like the UTIs, the pneumonia, they are also sometimes it has been observed that they are sometimes they become so untreatable because of this antimicrobial resistance. So I must congratulate the entire team of COPBELA for selecting such a wonderful topic. My whole heartfelt wishes are with you. And I am also looking forward to listen to the wonderful speakers who have joined up today. And really, definitely, I'm looking forward that we are also going to take up back home by listening to them. So a big congratulations to all of you, and my best wishes also are with you. Thank you so much.
Thank you very much, ma'am, to give a precious time for this IPGA Human Forum seminar. Jashan madam, let me start. Thank you very much, ma'am.
Thank you. Thank you so much.
Now, it is my privilege to welcome our esteemed speaker, Dr. Avneet Saini ma'am, Professor in the Department of Biophysics at Punjab University, Chandigarh. Dr. Saini completed her PhD in biophysics from Punjab University and has a distinguished academic career with extensive teaching and research experience. She also worked as a postdoctoral research fellow at University College London, UK, which reflects her strong international research exposure. Her research mainly focuses on design and structural characterization of novel antimicrobial peptides, peptide-based nanomaterials, and their biomedical applications. Dr. Saini has published more than 60 research papers in reputed international journals and has also been granted several patents in peptide therapeutics and biomaterials. We are truly honored to have her with us today. Now, I humbly invite Dr. Avneet Saini ma'am to kindly share her valuable insights on today's seminar topic.
Hello, I think I'm audible.
Yes, ma'am.
Thank you, Jashanpreet, for the wonderful introduction that you've just given. And I would first like to take this opportunity to really welcome the chairperson of the IPGA Women Forum, Professor Manju Singh Rawat, and at the same time also extending my thanks to her for giving me an opportunity to be a part of this lecture. And at the same time, COPBELA College of Pharmacy, Dr. Shailesh Sharma, Director cum Member Secretary, and the whole organizing team. It's always my pleasure to be with you and share whatever research we are doing and whatever is required for the society and as a science enthusiastic for the students. So I am always really welcome and would always be there for you all. And the topic that we are going to speak on today is antimicrobial resistance. So I think my slides are visible.
Yes, ma'am.
Okay. So coming directly to the topic. Um, today's national seminar is on antimicrobial resistance, a silent global pandemic. Now, these are very huge words, a silent global pandemic. Silent is that we just don't know when it happens and how it is just spreading amongst us. Global, the whole universe, the whole world, we all are affected by this. And pandemic, we are familiar with this term now since COVID pandemic. So we all understand that a disease or something that spreads across the globe worldwide, it becomes pandemic. Whenever we say epidemic, it is limited to a smaller area, smaller zone. But when it is pandemic, it means the whole world, all the continents, they are affected. And antimicrobial resistance is becoming that big a problem. We are used to talking about cancer, we are used to talking about HIV, AIDS, but antimicrobial resistance and the problem it is going unnoticed because we don't feel directly affected by it. So I'll keep my lecture very simple and even for the layman, because this is something that all of us, whether we are from science, non medical, arts, or just a common lady or a man going about, needs to understand. So I would stick to the basics so that each one of us can understand and we can take this into our daily life and at least inculcate some good practices so that we can avoid antimicrobial resistance. And in that way, I think we would be contributing our bit towards the society so that we prevent this silent global pandemic from spreading further. So we need to first understand what is antimicrobial resistance. So microbes, we all understand they are the small microbes, small organisms, whether they are bacteria, virus, fungi, they all are microbes. And antimicrobials, they are medicines that kill or slow the growth of microorganisms that cause disease. Antimicrobial resistance is when microorganisms change to resist the effects of antimicrobial medicines, such as antibiotics. We all rely on antibiotics, antivirals, antifungals. But when the microbes become resistant to the drugs, that is when antimicrobial resistance comes into play. So, what happens then? Antimicrobial resistance leads to treatment failure or inability to treat the cause of infection. That is why it is being considered a silent pandemic. We are still looking at the disease कि वो disease ठीक नहीं हो रही है, we are not able to cure it, but at the end, bottom line is that our drugs are not working. And why they are not working? Because of microbial resistance. So that silent pandemic we are unable to understand or foresee. So it spreads slowly and is going unnoticed. And if left unchecked, it could lead to a post antibiotic era where common infections would become untreatable. And we are very commonly referring to this as post antibiotic era. And we have already entered this post antibiotic era where common infections would become untreatable. So, just a brief history of the antimicrobials, how these medicines started. So, we all talk about antibiotics, but the start of antibiotics was from penicillin in 1928 when Fleming discovered it. And it was by serendipity. He was looking at some other microorganisms and conducting some other experiment when he found that the bacteria was not growing around some area. And when he looked into why bacteria was not growing over there, then he noted that there was a mold over there which was secreting some chemical which was inhibiting the growth of the bacteria. And that chemical was penicillin. So from there, we discovered the first antibiotic. And since then, it has changed our whole history. But at that time also, it was very difficult to extract penicillin with purity and on a large scale. So it was in 1940s, before the World War II, when Florey and Ernst Chain, they developed a mass production method for penicillin, and that started the antibiotic era. And it was in the during the World War II that we benefited from this finding, and so many soldiers were cured using the antibiotics. And it was such a big discovery that the 1945 Nobel Prize in Physiology and Medicine was given to Fleming, Florey, and Chain. And thereafter, after 1945, 1950s to 1970s is considered the golden age of antibiotics, when a number of antibiotics were discovered: streptomycin, tetracycline, and many others. They transformed healthcare and life. But from 1980s, resistance started emerging, and there were first reports of penicillin resistance, and thereafter the cases of resistance, they kept on increasing. And as we hit 2000s, the modern era of antimicrobial resistance, it has set up with the discovery of NDM1. And NDM1 stands for New Delhi metallo-beta lactamase. So this resistant strain was found in New Delhi in India. So that is why we need to really focus on antimicrobial resistance, because our country is one of the major sufferers from this silent pandemic. So, looking into microbial resistance, According to World Health Organization, AMR is one of the top global public health and development threats of the 21st century. Each year, antimicrobial resistance is killing 1.3 million people worldwide, and the problem is getting worse day by day. India is among the countries with the highest rate of antimicrobial resistance. And major resistant organisms include Klebsiella, E. coli, Pseudomonas, Staphylococcus aureus, and Acetobacter species. So all of them, they are turning into major resistant organisms, and that is posing a great threat to our healthcare machinery. So this is, I have just taken this from a surveillance report of ICMR, Indian Council of Medical Research 2023, which gives the status of antimicrobial resistance in India. So AMR, according to this, has been increasing in the past few years, basically due to the overuse and misuse of antimicrobials, including antibiotics among people as well as animals. So, animals is the one category that often goes neglected because we are more concerned about our own health. Who is looking at animals? But animals are the major breeding grounds and spreading ground of antimicrobial resistant due to indiscriminate use of antibiotics to them. And once given the antibiotics, they just don't disappear with the animal. They stay in the environment, they enter the water, they enter our rivers, streams, soils, and that is how they enter the whole food chain cycle. So we have to be very vigilant when considering our livestock and our animals as well. Then the latest ICMR national survey that was conducted in 2020, it was on 30 tertiary care hospitals across the country. And in all of them, antimicrobial resistance was found quite high for all the different species of bacteria, whether it's E. coli, Klebsiella, Pseudomonas, aeruginosa, Staphylococcus, so everywhere. And what are our major concerns? Now, colistin, we all know they are the last resort drugs that are used in our hospitals during surgeries and all. So, overall susceptibility of 96% with E. coli and over 90% with Klebsiella, but colistin resistance is now growing. That is one of our major concerns. Then the other concern is resistance to carbapenems. Now, these are the mainstay in many ICUs. It is increasing with 40% in treatment of Klebsiella. So that is how we are moving towards growing resistance towards microbial antibiotics. So, what is ICMR doing? It has grouped the pathogens into group 1, group 2, and group 3 according to high risk and high risk probability for multi drug resistant bacteria. And it conducts surveys across the country and provides these reports so that we can be vigilant. Now, this is the status of antimicrobial resistance mortality. That is how many people are dying in different countries. So it's like a heat map. So the red ones that tells us the highest mortality rate, and then is the orange and the light orange. So you can see that we lie in the dark orange type zone, moving towards red after Africa. So it is quite higher mortality, and this was the Lancet report in 2024. So we need to be very careful now because we are striding in rough waters. So we call it a global time bomb now. Antimicrobial resistance is called a global time bomb. Why? 4.95 million deaths in 2019, already the 10th leading cause of mortality worldwide. 10 million deaths are projected by 2050. And if current trends continue, more than cancer it would become. And if we talk about economy, it is $100 trillion economy, loss of productivity, healthcare costs, they are increasing, and this would be the cost that we would need to bear by 2050. So that is according to World Bank. So the world faces only one choice. We need to act now or face a post-antibiotic era where common infections would become untreatable. So it is our choice where we want ourselves to see. So this is just a landmark antimicrobial resistance event that happened in 2000s that was of NDM1 case, New Delhi metallobeta lactamase, which was first detected in bacteria isolated from patients who had received medical treatment in India, and that was specifically New Delhi. So, highly resistant pathogen commonly found in Klebsiella and E. coli. The NDM1 enzyme can inactivate carbapenems, which are often used as the last resort antibiotics. And within a few years, NDM1 was detected across different continents: Europe, North America, Asia, and it largely traveled through people traveling and healthcare networks. So, the discovery of NDM1 was a turning point in the global fight against antimicrobial resistance, and the all scientists and the WHO, they all became very, very vigilant that we are heading towards a pandemic. It showed how a resistant gene emerging in one region can spread across continents so fast. The Lancet Infectious report presence of NDM producing bacteria even in drinking water sewage samples in New Delhi. It showed that antibiotic resistance can move from hospitals into the environment. That is what I was talking about, that even our waters, even our land, our soil, they are infected. And this was one of our publication in 2012, where we were amongst one of the first to write an article on the same NDM1 crisis that we would be facing. Now, carbapenem resistant Klebsiella, it is again a growing threat in Indian hospitals. Now, what are we doing? ICMR surveillance has detected alarming levels of carbapenem resistant in Klebsiella pneumonia in Indian hospitals. And that is why we talk about hospital acquired infections. So these infections are most common in ICUs and ventilator associated patients. Carbapenems are often the last line antibiotics. And when the last line antibiotics stop working, doctors are left with very few treatment options. And then we say, "कि ठीक ही नहीं हो रहे हैं, ठीक ही नहीं हो रहे हैं." How would we know? Because we are a part of the silent pandemic. It is not the disease, but it is the ineffectiveness of the drug that is killing people. Now, this is another Times of India report: superbugs threaten hospitals as antibiotic resistant rises. So, this is a PGI study, ICMR report 2024. So, the opening sentence itself is alarming. It says, "What if a simple cut or common infection turns deadly because our usual medicines no longer work?" That's the scary reality of superbugs. So that is where we are headed. Even a simple cut, it would become incurable. So this report, it had 8 major hospitals as participants from across India: All India Institute of Medical Science, AIMS Bhopal, AIMS Rishikesh, AIMS Bathinda, AIMS Jodhpur, and AIMS Raebareli, along with Government Medical College Baroda, with the center being at PGI. So this is quite alarming a report that has led all our doctors and scientists to think and rethink where we are headed. Why should we care about AMR? I think this is quite clear till now that we are headed towards the post antibiotic era where our common drugs would become ineffective. So, even a small cut could become infectious and turn life threatening. Surgeries, dental procedures, they could become high risk. Cancer therapy, chemotherapy, organ transplants for that matter. Infections like UTI, pneumonia, they may become untreatable, or many of us might have encountered a routine simple UTI infection not getting treated in due course, extended time of medicine, treatment again and again. Why so? Because the bacteria, the microbes, they are becoming resistant. So almost every modern medical procedure depends on antibiotics to prevent infection. And what if antibiotics are becoming ineffective? We need to think on that. So, we've already discussed why it is called the invisible pandemic. 1.27 million annual deaths, more than HIV and AIDS, even malaria or breast cancer. Yet, we are not able to see it coming. It is invisible to the public. Its transmission is invisible. It spreads silently through communities, through hospitals, across continents, food chains, through soil, through environment. And it has a global reach. It is affecting every country, regardless of wealth, healthcare system, or geography. Everyone is getting affected silently. So that is the main problem. So this is again a WHO report of 2023 where it is projecting deaths from antimicrobial resistance, AMR, antimicrobial resistance and infection by 2050. So the dark blue bar shows the scenario in 2020, where cancer has around 10 million deaths and antimicrobial resistance is at 1.3 million. But by 2050, look at the light blue, royal blue graph for antimicrobial resistance. It is nearing the same as cancer. So it is growing that fast. That is why it has become so alarming a problem. So that is the projection. So now what are the causes? What are the causes? Why antimicrobial resistance? Why microbes are becoming resistant to our drugs? Why our medicines, they are not working? So overprescription of antibiotics. Now, I think this is one of the main problems in our country. Overprescription. Khansi hai, jukam hai, antibiotic. Every doctor, I have small kids, antibiotics, antibiotics. Patients not taking antibiotics as prescribed. I have seen, you all might have examples in your families. डॉक्टर ने ज्यादा strong medicine दे दी है मैंने अपने आप कम कर दी dose. We take a wrong prescription, not taking antibiotics as prescribed. What happens? The small dose stays in our system. It keeps on staying, and the bacteria, it is exposed to that small dose, which is not killing it, but it is telling the bacteria how to live with it. And the bacteria is able to develop resistance. It is learning to grow with it. So the third one is unnecessary antibiotic used in agriculture, livestock, animals. We all are aware of that. Then is poor infection control in hospitals and clinics, sanitation, infection control, precautions, cleanliness in our hospitals and clinics. That is poor, and that is why they are becoming breeding grounds of infection and hospital acquired infections. I think almost all of you, we might have heard during COVID times कि मैं तो वैक्सीन लगवाने हॉस्पिटल गया था मुझे कोविड हो गया. That is not untrue. It happened with many people because hospitals became breeding grounds. Hospital acquired infections. It happened. That is true. Then poor hygiene and sanitation practices. That is also very common in our country. You go to the local toilets or the local market, you will see poor hygiene and sanitation. And lack of rapid laboratory tests. We are not focusing on quick rapid laboratory tests to identify the problem. So that is another factor. So, besides these main factors, there are other contributing factors to drug resistance, like inadequate infection control, social factors. डॉक्टर के पास जाने की जरूरत नहीं है, देसी नुस्खे कर लेते हैं, नहीं नहीं देखो थोड़ी देर. Lack of rapid diagnosis, we've already discussed. Overuse and misuse. Misuse है, you are not going to the doctor, you are self-prescribing yourself. That is misuse. Increase in number of immunocompromised patients. Now patients जिनका health care, जिनका immune system वैसे ही weak हो चुका है, so उनका भी number increase हो गया है and they become more prone to antimicrobial resistant drugs. Agricultural use, evolution of microorganisms. See, everything in nature evolves. Evolution is the basic thing that happens on the earth. So microbes, they are very ancient organisms and they learn very rapidly to evolve with the changing environment. So evolution of microorganisms is another factor. Lack of alternative therapeutics. Now, since antibiotics in the last, if you look at how many antibiotics have been discovered in the last 20 or 30 years, you will find very few. It was just in the golden era of antibiotics, 1950s to 70s, that most of the antibiotics had been discovered. But now, no new antibiotics. So we need to look at alternate therapeutics, that if these stop working, what do we have or what are we looking at? So we need to conduct research in these alternate therapeutics. And incomplete treatment course. We all know that. Doctor बोलेगा 5 दिन antibiotic खाना ही है. But many a times we don't. एक dose miss हो गई, दूसरी miss हो गई. So that is a common practice in our society. So all these factors, they are leading and contributing to resistance development. Now, this is just a very simple slide that I have kept to show mechanism behind antimicrobial resistance. So what happens is, so this orange one is a non-resistant bacteria, a normal bacteria. You are exposed to a normal bacteria, infection occurs, the bacteria multiplies and it grows. You give it a drug, the drug kills the bacteria, it dies, and the person becomes healthy. But when you have a drug resistant bacteria that I've shown in the purple, the bacteria multiplies, and then what happens? The drug is not able to kill it. It is not working against this drug, against this bacteria. So then the bacteria keeps on multiplying again and again, and the person remains sick. You are not treated. Now, what happens is in our environment, in our body, whenever we have infection, we have the normal bacteria along with one or two scarcely here or there drug resistant versions. But when we give antibiotics, the antibiotics kill the normal ones as well as the healthy bacteria. Now, what happens? The multi drug resistant strain, it is left alone. It has the whole system to itself to grow and to multiply because the drug is ineffective against it. And we've already killed the healthy bacteria also with the antibiotic because the antibiotic cannot discriminate. So then all others are not present, and we only have the growth of the drug resistant bacteria, which now grows and multiplies and takes over the entire system. And this bacteria, it is also capable of transferring its drug resistant to a healthy back to a normal bacteria, making it drug resistant. Because bacteria evolve very quickly, evolution happens in them, and they transfer their genes through horizontal gene transfer to the normal bacteria, converting it to a drug resistant bacteria. And that is how more and more bacteria are becoming drug resistant. So, how does antimicrobial resistance spread? So, I have also talked about all of these. Animals, we give antibiotics. Then, people who are infected, we give them medicines. Then, through animals, these antimicrobial strains, they enter our food chain, our fertilizers, water, even the soil. And when a person is infected, he comes in contact with other people and he goes to the hospitals and all. So it is like the whole society, the whole place, it gets involved, and resistance keeps on spreading further in the community silently. So that is how this silent pandemic works. So, genetic mutation, horizontal gene transfer, and biofilm formation are key mechanisms through which the microorganisms acquire and spread antimicrobial resistance because they help them to survive in the presence of antibiotics. Now, there are different levels of drug resistance. I'll just briefly tell that so that the students know that there are other terms except the multi-drug resistant strains. So MDR stands for multi-drug resistant. Then we have extensively drug resistant. Then we have PDR, pan-drug resistant. So multi-drug resistant is simply एक से ज़्यादा drugs in different categories जो काम नहीं कर रही हैं. Extensively drug resistance, दो या उससे ज्यादा ड्रग्स इन डिफरेंट कैटेगरीज जो काम नहीं कर रही हैं. एंड पैन ड्रग रेसिस्टेंट इज कि थ्रू आउट कोई भी ड्रग काम नहीं कर रही है. सो दैट इज हाउ these bacteria and the resistance is categorized. So now coming to the challenges associated with implementation of antimicrobial resistance. So limited access to quality healthcare services. Healthcare services need to improve. There is limited access for the general public to quality healthcare. Weak healthcare infrastructure, infection prevention practices, socioeconomic disparities, limited awareness. Many of you, many of the common people, they are still not aware of what is antimicrobial resistance, what we need to be aware of, how we need to take the medicines, what happens if we don't take the drug or the medicine in proper dose and at proper time, inadequate surveillance systems and data collection, and limited regulatory frameworks and quality control. Now, I think in our country, limited regulatory framework is also a major factor that is contributing to antimicrobial resistance, because you go to a medical store, you tell him ye chahiye, even if it is a banned drug or it is a H1 class drug which cannot be given without prescription, you will commonly find it at a chemist store and he would easily give you. So limited regulatory frameworks are operative in our country. That is also a very big problem. Okay, so for me, this is a very, very important slide that each one of us needs to understand, that we must understand the difference between use, overuse, misuse, and abuse of a drug. Now, use is proper use. Bimari, आप doctor के पास गए, doctor analyzed, he gave you a medication, and you are taking it as prescribed. That is use. Overuse, you extend the dose. You, if he's given you 500 mg, you say no, okay, मेरे को जल्दी ठीक होना, I'll take a 600 mg. Or he's given it to you for 3 days, you say no, I'll take it for 6 days so that आगे भी ना हो. That is overuse. Misuse is incorrect usage, using it in the wrong way, wrong dose, wrong duration, even wrong time, stopping the course early. That is a simple example of misuse. कि पता है आपको इस prescribe भी हुआ है, but still you are misusing it. Now, abuse of antibiotics, that is irresponsible or illegal use, deliberate or unethical use of antibiotics, often without medical guidance. जब हम medical guidance prescription के बिना रह रहे हैं, that is abuse, which is very, very common in our country. Self-medication, pharmacies selling antibiotics illegally, adding antibiotics to animal feed to promote faster growth. All of this comes under abuse. So we need to understand, we need to be responsible citizens while using medicines. Now, here comes the role of WHO. Now, since WHO, World Health Organization, it has recognized antimicrobial resistance as a growing major pandemic, a silent problem. So it has also launched a global action plan. It launched it in 2015, and in a phased manner, it keeps on improvising and adding on to this plan. So it has five main subheads. The first one being improving awareness and understanding of antimicrobial resistance. Second is strengthening surveillance and research. Now, this is very, very important so that we have a correct estimate and statistical data about the problem. Third is prevent infections through sanitation, hygiene, and vaccination. So that is another thing that our government is also working on, and every hospital and local areas, districts, states, they are trying to work on. Then the fourth phase is optimize the use of antimicrobial medicines. Now, optimizing the use, it also includes general public. We all need to be aware so that we can move towards optimized use of antimicrobial medicine. And this lecture is also, I think, a part of optimized use of antimicrobial medicines and spreading awareness. So the fifth one is invest in innovation. So invest in innovation is another area where government is keenly working on. ICMR is working on. It is promoting research and development in major areas involving antimicrobial resistance so that we come up with innovative ideas, innovative therapeutics and diagnostics for this big problem. So, continuing with WHO's role, so it has set up a GLASS, that stands for Global Antimicrobial Resistance Surveillance System, in 2015 to collect and share data on antimicrobial resistance from countries around the world. Awareness campaigns are being organized, and as a part of awareness campaigns in November 18th to 24th every year is, this week is being used for spreading awareness in the world against antimicrobial resistance. And WHO is also providing support to countries so that they develop their own national action plans to control AMR. And talking about the national action plans, WHO has also focused on One Health approach because, as I said earlier, it is not only we humans that are affected, animals are also major contributors. And so the whole environment, our rivers, our soil, they all are becoming involved. That is how it is one health problem, that we need to include the human health, environment health, and animal health all together in approaching this larger problem. So now this is the national action plan for different countries. When they launched, US, it started in 2014, national strategy, all 50 states. UK also started early in 2013 with its first 5-year plan for national coverage. We in India, after WHO in 2015 declared this as a pandemic, we started in 2017, and our quite popular is the Red Line campaign. I'll be talking about this. It was launched across 12 states. Then China, Brazil, these are other countries who've also adopted, and there are many more who are entering the plan. So this is just a dossier picture of the National Action Plan on Antimicrobial Resistance by the Government of India. The first one was launched in 2017, and this is the latest edition, 2025 to 2029 Outlook. So it is by the Ministry of Health and Family Welfare, and it gives 6 strategic priorities in its plan. Now, these are the 6 priorities that are given in the National Action Plan in line with WHO. We've just brushed across all of them. So I'll just skip this. So when we talk about India's National Action Plan against antimicrobial resistance, so the key initiatives are being taken mainly by ICMR at the ICMR level, surveillance programs. And under the surveillance programs, the PGI report that I showed you, that was a part of the surveillance program. Then Food Safety and Standards Authority of India, FSSAI. So it also controls antibiotic residues in food. It also categorically looks for antibiotic residues. Then we have National Center for Disease Control. It also coordinates AMR activities nationwide. And then is the Red Line campaign of the government. Now, what is this Red Line campaign? Now, you all might have seen such medicine packs, but we often miss out this red line. Can you see my marking, anybody? This red line. So all these packings which have these red line, they tell us that these medicines are not to be taken without a medical practitioner's prescription. We need to consult the doctor before taking such medicines. And when we take these medicines, we should duly take them in the due course as prescribed. जितने दिन जितनी डोज properly जिस टाइम उस तरह ही हमें खानी चाहिए. So that this red line जिन जिन antibiotics medicines पे हैं उनको हमें थोड़ा ध्यान से लेना चाहिए. एंड ये नहीं कि मेरे को दी है खांसी के लिए, गला खराब के लिए, चलो जी मेरे भाई का गला खराब हुआ, तू भी यही ले ले. We should stop this. This is misuse. We need to be vigilant and aware educated citizens, and we should go to a doctor and take them in with the proper prescription. Now, list of drugs not permitted for over-the-counter sale in India. So, levofloxacin abhi bhi milti hai. Rifampicin, Moropenem, Dorepenem. So all of these that I have listed, they all are not for sale over the counter in India. कि ऐसे ही जाके आप फार्मेसी से आप मेडिकल स्टोर से लेते हैं. Schedule H1 is a subcategory of Schedule H of the drugs, which regulates the sale and distribution of prescription drugs in India. And all of them, they are the Schedule H1 drugs, and they should not be sold over the counter. But since I have small kids, I am well aware levofloxacin ऐसे ही मिल जाती है. So there are many more, and many of you might be aware कि ऐसे ही मिल जाती है. So our regulatory system still needs to work on, and it should be more stringent if we are to take this problem seriously. So just a brief, different states in India, they have also launched their initiatives and state level action plans. Kerala, Madhya Pradesh, Delhi, Maharashtra, Tamil Nadu, Gujarat, and Punjab also have developed their state action plans. Schedule H1 drugs pay restriction over the counter hai. Kerala, I've heard, is more strongly implementing this, that over the counter drugs ki sale and purchase pe they are keeping a quite tight eye. AIMS and PGI-AMR has active AMS programs. They are actively participating in the surveillance programs also. FSSAI limits antibiotic residues in foods and animal feed. And one example is the ban of the use of colistin in poultry and animal feed. This was implemented in 2019. So we are moving ahead with the plans. So this is Operation Amrit in Kerala. So that is antimicrobial resistance intervention for total health. So they've launched this and they ensure stricter prescription practices and reduce over-the-counter sale of Schedule H1 antibiotics. Punjab also launched its state action plan for containment of antimicrobial resistance, and it was announced just last year, September 2025, by the then health minister. So, India's fight against antimicrobial resistance, the key initiatives have to be phased ban on over the counter antibiotics. This has to be done in a stricter manner. Digital prescription tracking system. आजकल तो digitally भी prescribe हो रहे हैं and tracking systems have to be in place and vigilant. Hospital antibiotic policies and stewardship. Many of you might be saying doctors ही prescribe कर देते हैं. I agree with you. Doctors are also over prescribing antibiotics. So hospitals also need to look into their antibiotic policies. Public awareness campaigns like these for the public. Abhi to we all are still related to sciences, but we need to go to the masses, general public. Each one of you, if spreads a word, aage, maybe we can spread a bit of awareness. So that is also required. Mandatory training for pharmacists. Now, this is very, very important to stop over the counter abuse of drugs and misuse. Then is environmental and agricultural controls. So we are moving towards agricultural control and livestock controls, but there are much more efforts that are required and need to be done. So future strategies to combat antimicrobial resistance, like what are we looking at? If antibiotics are not working and in the last 20 to 30 years, only a very few new antibiotics have entered the market, then what are we looking at? We need to develop future strategies that if not antibiotics, what then? So there's a lot of research going on different categories, development of rapid diagnostic tests, expanded surveillance, elimination of growth promoting antibiotics, multinational collaborations, research and development for new therapeutics, and antimicrobial stewardship. So there are different aspects in which government is working, researchers are working, scientists are working. So we are working, but we need to actively participate and do more in this field. So, to combat antimicrobial resistance, what I can talk about is newer therapies and alternatives for antimicrobial resistance. So, we need to look at novel drugs and molecules. Apart from antibiotics, we should look at other effective alternatives to antimicrobials like bacteriophage therapy, antimicrobial peptides, nanotechnology, nanocarriers, nano-antibiotics, so that may hold a future for this problem. And lastly, prevention and supportive strategies. Now, how can we prevent and what are other supportive strategies like immunotherapy? So, those are also the fields that have to be looked into. And if I talk about my field, what we do as for this problem, so this is where we work antimicrobial peptides and nanocarriers and nanoantibiotics. So that is our bit of contribution towards the society where we are looking into different novel peptides that have broad spectrum activity against bacteria that are becoming resistant. So this is just a brief, how much time? Okay, this is just a brief of the peptides and the nanoconjugates that our lab work on. So we work on developing antimicrobial peptides that are active against a broad range of antimicrobials, and especially focusing on bacteria. So we design and develop synthetic peptides because peptides, they do not develop resistant. They are still active. They don't bacteria don't become resistant to peptides. So that is our main catch over here. And they've shown broad spectrum activity against a number of bacteria, hospital acquired infections, multi-drug resistant strains. So that is what we do. And then we use these peptides, we design them, we study their molecular structures, we look into their in vitro efficacy against different strains, their toxicity, and then take them to in vivo animal models to look into their efficacy, maybe in wound healing, giving an infection and looking into the wound healing capabilities, maybe using them in dressings or as hydrogel patches, whether they have therapeutic efficacies. So these are few things that we do, and I think we have around 3 patents for different peptides and technologies that we've undergone. And another aspect is these peptides, we combine them with nanomaterials, giving them surface and making peptide nanoformulations, which then find different applications. So one of the application is using this formulation as an antibacterial additive for wall paints. So this is one patent that we hold, and we are currently in talks with Berger Paints and giving them the first samples for testing how, because the main focus is to work in hospitals where the area is prone for hospital acquired infections. The other is antibacterial catheter coatings. So now catheters and all are used for urinary problems and all, and they are highly prone to bacterial infections. So that is another area where we work as by developing coatings for that. And the third one is in our therapeutic interventions, using it as a bandage or as a patch. And in all these, especially in therapeutic interventions, we found our material to be quite effective even when antibiotics were failing. So coming to the last slide, take home message. What can we do to prevent antimicrobial resistance? The first thing that I think for a common man is to understand the difference between use, overuse, misuse, and abuse. That is very, very important. We all need to understand. We need to be vigilant. We need to be careful. So we should only use antibiotics when prescribed by a certified healthcare professional. Never consume leftover antibiotics. We should never share your antibiotics with others. We should always take the full prescription, even if you feel better. Now, this is very, very important. And lastly, prevent infections by regularly washing your hands, avoid contact with sick people, and keeping your vaccinations up to date. Now, this is also key to keeping infections and resistance at bay. So I would be happy to address any queries or any questions.
Thank you very much, ma'am.
Thank you, sir. Thank you.
We have one query. How we can come to know कि we are come into the antimicrobial resistance?
We all are a part of antimicrobial resistance. हमें ऐसे नहीं पता चलता है. That is drug not acting properly. जब आपको प्रिस्क्राइब ड्रग है, 5 दिन की डोज है, थोड़ी देर आपको लगे बीमारी ठीक ही नहीं हो रही. कॉमन है ये यूटीआई इन्फेक्शंस, निमोनिया के केसेस में आजकल. सो एक्सटेंडेड लॉन्ग ड्यूरेशन के लिए हमें ड्रग्स दी जा रही हैं. तो वो ऑटोमेटिकली यही है. क्यों? क्योंकि पूल ऑफ बैक्टीरिया में जो पूल है, उसमें से आप लगा लो आधे से ज्यादा अगर ड्रग रेजिस्टेंट हो गए हैं, तो वो ड्रग उतनी अच्छे से काम ही नहीं कर रही है. देन स्लोली स्लोली वो पॉपुलेशन जब कम हो रही है, नॉर्मल तो हट गए हैं, तो अपना इम्यून सिस्टम भी तो है, वो फाइट कर रहा है साथ की साथ, एंड कर करके स्लोली हम ठीक हो रहे हैं या हम स्ट्रॉन्गर मेडिसिन की तरफ जा रहे हैं. दैट इज द ओनली वे. एंड असली इफेक्ट पता चलता है जब हम किसी मेजर सर्जरी में फंसते हैं, हॉस्पिटल में हैं, या ओल्ड एज पीपल हैं, इम्यून कॉम्प्रोमाइज्ड है, वेंटिलेटर पे हैं, वो फंस जाते हैं फिर. क्यों? क्योंकि उनकी इम्यूनिटी लो होती है, उनका अपना इम्यून सिस्टम इज नॉट एबल टू वर्क.
Ma'am, one of the delegate asked one question कि how we diagnose it कि antimicrobial resistance आने लगा है.
डायग्नोस तो कल्चर से होगा. जब बैक्टीरिया कल्चर होंगे और पता चलेगा ये स्ट्रेन एग्जिस्ट कर रहे हैं. अदरवाइज इट इज साइलेंट. वही तो बात है.
Facilities available to diagnose.
यस यस यस. डायग्नोस जब आप सैंपल देंगे कल्चर में, जब आपकी ठीक ही नहीं हो रही है बीमारी, देन दे विल डू कल्चर. ये आपकी यूरिन कल्चर भी तो करते हैं. अभी तो हम सिंपल यूरिन कल्चर करते हैं किसी भी प्रॉब्लम में कि जी देखें क्या है, फंगल है या क्या है. लेकिन अगर उसके ट्रीटमेंट के बावजूद वो ठीक नहीं हो रहा, देन दे विल गो फॉर एक्सटेंसिव स्ट्रेन टेस्टिंग. तब पता चलता है कि ओहो ये तो स्ट्रेन ड्रग रेजिस्टेंट वर्जन आ रहा है.
Madam, one of the delegate asked a question कि new एंटीबायोटिक्स जल्दी AMR में आ रही हैं या फिर ओल्ड जो एंटीबायोटिक्स हैं वो
न्यू एंटीबायोटिक्स है ही नहीं इतनी। 1980s के बाद हार्डली 10 भी नाम नहीं होंगे जो आपको मिल जाएंगे। इट इज जस्ट ओल्ड, जितनी वो थी उन्हीं के कॉम्बिनेशंस।
वो यही जानना चाह रहे हैं जो पेनिसिलिन एमोक्सिसिलिन वगैरह थी वो जल्दी AMR में आती हैं या जो नई वाली कैटेगरीज हैं वो जल्दी?
कॉम्बिनेशन ही उन्हीं सभी के हैं,
कॉम्बिनेशन
इंग्रेडिएंट वही हैं, इंग्रेडिएंट वही है। उन इंग्रेडिएंट्स को इधर उधर करके हम नया शरबत की फॉर्म में ले रहे हैं, बट उस शरबत के सारे इंग्रेडिएंट्स के अगेंस्ट रेजिस्टेंस बन रही है। ये है।
चलिए, थैंक यू वेरी मच मैम।
थैंक यू जी।
Now, our next distinguished speaker is Dr. Rupal Mittal, ma'am, Head of the Department of Pharmacology at RKSD College of Pharmacy, Kethal. Dr. Mittal has a strong background in pharmacy and biomedical research and has been actively involved in teaching, research, and mentoring students for many years. Her research work mainly focuses on medicinal plants, bioactive compounds, and their pharmacological potential in modern healthcare. She has authored several research articles in reputed journals and continues to contribute significantly to the field of pharmacology and natural product research. We are delighted to have you with us today, ma'am. Now, I humbly invite Dr. Rupal Mittal, ma'am, to kindly deliver her talk and share her valuable insights with us.
A very good afternoon, everyone. And today, on occasion of Women's Day, our strength, our resilience, and our voice. And I want to begin by asking a question. Who has always been the first line of defense against infection in every home, every community, every generation? It has always been a woman. The mother giving antibiotics to her child, nurse administering treatment, and a resource ward. Women are at the center of crisis as caregivers, as patients, as health workers. Today, I'm here to talk about one of the most dangerous global threats. The world is sleepwalking into antimicrobial resistance, a threat where drugs we have trusted for decades are quietly becoming useless. So, starting with antimicrobial resistance, antimicrobial resistance is a global health crisis, a silent pandemic threatening modern medicines. So, slides are moving.
No, ma'am, these are not moving. Yeah, we are on second slide.
Okay, thank you, sir. Antimicrobial resistance. Today we will cover what is antimicrobial resistance, global burden of AMR, environmental dimensions, antimicrobial resistance, and sustainable development. So what is AMR? AMR, defining antimicrobial resistance. Antimicrobial resistance occurs when microorganisms, bacteria, virus, fungi, and parasites change its ways that renders ineffective medications used to treat the infections they cause. Means bacteria में methicillin resistant staphylococcus aureus bacteria, multi-drug resistant tuberculosis, carbapenem resistant E. coli. वायरसेस में एंटीवायरल्स में आपका एंटी रिट्रोवायरल रेजिस्टेंस, इन्फ्लुएंजा, HIV is autoimmune disorder. Fungi, Candida albicans, and parasites में vector-borne disease is there, malaria. How antimicrobial resistance develops? First is overuse and misuse of antibiotic, that is antibiotic exposure. Bacteria are exposed to antibiotics in human, animal, and environment. Human for the treatment of infections, animals for livestock, and in environment, either effluents from pharmaceutical industries, either effluents from manufacturing units, either effluents from fields. All are concentrating antibiotics. Second, natural selection. Through the evolution, most of the bacteria are killed and a few randoms with random mutations and survive. Third is resistant strains multiply. Surviving bacteria reproduce rapidly, passing on resistance with genes. Gene transfer, resistance genes spread bacteria via plasmids, horizontal gene transfer. 6 key drivers are there for antimicrobial resistance as per WHO. Misuse and overuse of antimicrobials in humans and animals, self-medication, incomplete courses, agricultural overuse, weak infection control, inadequate prevention in healthcare facilities and farms promote spread. Poor wash. Poor washes, WA is for water, S for sanitation, and H for hygiene. Poor washes, lack of clean water, sanitation, and hygiene. Limited access. Limited access to what? Quality diagnostics. बिना डायग्नोस्टिक्स के जब एंटीबायोटिक्स दिए जाते हैं तो वो एक लिमिटेड एक्सेस है. वैक्सीन ऑल्टरनेट हो सकते हैं लेकिन वैक्सीन लिमिटेड रहती हैं. लैक ऑफ अवेयरनेस. पब्लिक अवेयरनेस किया जाना चाहिए कि एंटीमाइक्रोबियल रेजिस्टेंस डेवलप हो रहा है तो एंटीबायोटिक्स को प्रॉपर यूज कैसे कर सकते हैं ताकि वो खराब ना. वीक एनफोर्समेंट. जो रूल्स एंड रेगुलेशंस इंप्लीमेंट किए जा रहे हैं वो ग्राउंड लेवल तक नहीं पहुंच पा रहे हैं. डिफरेंस बिटवीन नेचुरल एंटीमाइक्रोबियल रेजिस्टेंस and human accelerated antimicrobial resistance. Natural antimicrobial resistance occurs over millions of years. It is an evolutionary process, part of the natural microbial ecosystem. Bacteria in pristine environments carry some resistance genes, जो धीरे धीरे डेवलप होते हैं और धीरे धीरे ही हमें दिखते हैं. तो एस्टिमेट किया जाता है कि जो जीन आज चेंज हुआ है वो नेक्स्ट 10 years में दिखने वाला है. ह्यूमन एक्सेलरेटेड AMR में क्या हुआ? एंटीबायोटिक मिसयूज, ओवरयूज स्टार्ट हुआ. इंडस्ट्रियल एग्रीकल्चरल वेस्ट एनिमल्स तक जाने लगा. फार्मास्यूटिकल वेस्ट कंटेमिनेट करने लगा वाटर बॉडीज को. ग्लोबल ट्रेवल्स एंड ट्रेड ऑल्सो spreads of strains and resistance developed faster as earlier. Superbugs. Microorganisms today are also known as superbugs. First category is escape. Escape stands for Enterococcus, Staphylococcus aureus, Klebseilla, Acinetobacter, Pseudomonas, Enterobacteriaceae. These are the leading microorganisms that are hospital-acquired pathogens. Second is methicillin-resistant Staphylococcus aureus, mainly causes skin diseases, bloodstream and pneumonial infections, and it is resistant to penicillins. Gonorrhea. Neisseria gonorrhea is a sexually transmitted disease and almost no antibiotic is working against gonorrhea these days. CRE. CRE is carbapenem resistance Enterobacteriaceae. Candida aureus. This is antifungal drug. Antifungal. This is fungal microorganism and multi-drug resistance tuberculosis, isoniazid, rifampin, antibiotic era. स्टार्ट होता है ये 1928 से. फ्लेमिंग ने पेनिसिलिन डिस्कवर किया था. तब हर एक इन्फेक्शन का एक सॉल्यूशन था, पेनिसिलिन विल कवर इट. गोल्डन एज स्टार्ट होता है. 1940 में फर्स्ट रेजिस्टेंस ऑब्जर्व किया गया अगेंस्ट पेनिसिलिन. 1960 में मैथिसिलिन रेजिस्टेंट स्टेफाइलोकोकस ऑब्जर्व किया गया विद इन जस्ट 2 years ऑफ इंट्रोडक्शन ऑफ मैथिसिलिन. 1980s में ड्राई अप होना स्टार्ट हुआ कि एंटीबायोटिक्स नए डिस्कवर नहीं हो रहे हैं कम काम हुआ. 1987 is the last year when a new molecule entered into the market. Since then, only 3 molecules have been entered till today. In 2000, drug-resistant TB, gonorrhea become global concerns. In 2010, colistin resistance is seen in animals. In 2019, 1.27 million deaths were attributed to AMR as per Lancet. And in 2024, in UNGA meeting, it was observed that 10% mortality reduction would be the target in 2030. Since COVID-19 is a pandemic, and from March to October 2020, almost 80% of the COVID-19 patients in USA received antibiotic treatment. Sir, is it audible?
Yes, ma'am, you are audible. Jashan ma'am, can you please mute your mic?
As COVID-19 approaches, we have no therapeutics. We have no drugs to cover up. कोई medicines नहीं थी, कोई precautions नहीं थी. वो उसी टाइम पे सर्च में जो काम किया जाता है, तो अगर इन्फेक्शन आया है तो हमें सोचा एंटीबायोटिक्स काम करेंगे. ओवरयूज हुआ उस टाइम पे एंटीबायोटिक्स का. एम्पिरिकल प्रिस्क्राइबिंग कोविड-19 increased antibiotic consumption, exacerbating resistance development. With the passage of time, हमें पता चला जो overuse हुआ antibiotics का, वो resistance develop कर रहा है. Disrupted surveillance. जब सब चीजें हम लोग थे, हम लोग होने की वजह से antimicrobial resistance के ऊपर monitoring program effectively work नहीं कर पाए. Supply chain disruption. Shortage of essential medicines and protective equipment weakened infection control measures globally. Healthcare associated infections. Critically ill COVID-19 patients were at elevated risk for secondary bacterial infections. Because highly dosed antibiotics are there for ill COVID-19 patients, they are immunocompromised that time. And infections are severely likely to act upon immunocompromised patients. Now, the question of global burden of AMR. आजकल क्या सिनेरियो है? क्या AMR के नंबर्स बता रहे हैं हमें नंबर्स बताते हैं कि जो डायरेक्टली एसोसिएटेड डेथ्स हैं AMR की, वो 1.27 मिलियन by 2019. Data is by 2019. And death associated with AMR in 2019 is 4.95. And this data could be increased to 10 million by 2050. जो GDP loss है annually, वो estimate किया जा रहा है कि $3.24 trillion में जाएगा. और इसका एक reason हो सकता है कि extremely poverty pushed peoples हैं 24 millions. AMR mortality. AMR mortality कैसे बढ़ रही है? AMR प्रोजेक्टेड है 2050 में कि ये 10 तक चली जाएगी. AMR impact on healthcare, high burden areas. अब कहाँ पर एंटीबायोटिक्स मेनली यूज किए जाते हैं? फर्स्ट, sepsis. Sepsis is intensive ICU mortality. ICU is intensive care unit. AMR complicates treatment of bloodstream infections, leading to cause of ICU mortality. Urinary tract infections, E. coli resistance fluoroquinolones now are major side of concern. Surgical prophylaxis. जब किसी की सर्जरी की जाती है पोस्ट ऑपरेटिव इन्फेक्शंस को रिड्यूस करने के लिए स्ट्रॉन्ग एंटीबायोटिक्स दिए जाते हैं. लास्ट रिजोर्ट एंटीबायोटिक्स दिए जाते हैं. पैथोजन क्लास 3 एंटीबायोटिक्स दिए जाते हैं. लास्ट रिजोर्ट एंटीबायोटिक्स का मतलब होता है लास्ट लाइन ड्रग्स जिनके साइड इफेक्ट्स ज्यादा हैं, लाइफ थ्रेटनिंग डिसऑर्डर्स में दिए जाते हैं, वो हम पोस्ट ऑपरेटिव इन्फेक्शंस के लिए देते हैं. न्यूनेटल इन्फेक्शंस. जब बच्चा होता है उसके अंदर एक टेंडेंसी रहती है ड्रग्स रेजिस्टेंस न्यूनेटल सेप्सिस की, इन्फेक्शंस की, तो उस टाइम भी एंटीबायोटिक्स दिए जाते हैं. सेक्सुअली ट्रांसमिटेड इन्फेक्शंस. गोनोरिया being untreatable, chlamydia resistance emerging in multiple countries. cancer chemotherapy. Cancer is a disease when your apoptotic pathway fails. So a number of antibiotics have been administered. So the patients become immunocompromised. In HIV patients, in cancer patients, in patients that have been ICU admitted, and patients that have organ transplant, all fall in immunocompromised patients because their immunity have been weakened so that disease couldn't hamper our body itself. AMR hotspots, where resistance concentrate. AMR कैसे डेवलप हो रहा है, किन किन जगह से एंटीबायोटिक्स रेजिस्टेंस डेवलप कर रही हैं या एंटीबायोटिक्स एक्यूमुलेट कर रही हैं. सबसे पहले ओवर यूज हेल्थ केयर फैसिलिटीज में, आईसीयू, होम केयर्स, फार्मेसीज, ये सारे के सारे ओवर यूज ऑफ एंटीबायोटिक्स कर रहे हैं. लाइवस्टॉक फार्म्स में कैटल्स आ जाती है हमारी, और कैटल्स इन्फेक्टेड ना हो, कैटल से मिल्क ज्यादा मिले और या फिर हैन से चिकन ज्यादा मिले, उसके लिए हम ओवर यूज ऑफ एंटीबायोटिक्स करते हैं. लास्टली वो क्या करता है, जो यील्ड हमें मिली है, मिल्क मिला है, वहां से हमें चिकन मिल रहा है, वहां एंटीबायोटिक्स रेजिस्टेंस डेवलप हो रहा है. एक्वाकल्चर, अब मेडिकेटेड फीड्स दिए जाते हैं फिशेस को ताकि वो इन्फेक्शन फ्री रहें और हमें इन्फेक्शन कोज ना करें, लेकिन पैसिवली वो हमारे अंदर एंटीमाइक्रोबियल रेजिस्टेंस डेवलप करते हैं. फार्मास्यूटिकल प्लांट्स जो एपीआई बनता है, वेस्ट वाटर कैसे डिस्पोज ऑफ किया जाता है, इसकी सर्टिफाइड रेगुलेशंस हमारी कंपनीज लोकलाइज्ड फॉर्म में फॉलो नहीं करते. इसीलिए चाइना में पटनहुड एंड इंडिया में हैदराबाद रेड रीजन्स बने हुए हैं कि वहां का वाटर एंटीमाइक्रोबियल रेजिस्टेंस डेवलप कर चुका. वेस्ट वाटर सिस्टम्स, सीवेज कैरीज रेजिस्टेंस जीन्स फ्रॉम hospital waste, household waste, rivers, refugee camps. A number of overcrowding refugee camps are there, jahan poor washes for water, sanitation, and poor hygiene. Limited health care create ideal conditions for AMR spread. So these are the 6 parameters that are interconnected and elevating AMR. Antimicrobial resistance, antimicrobial pipeline crisis. As we have discussed earlier, no new antibiotic class have been discovered since 1987. Major pharma companies have been involved in inventing new drugs relating to mental health, relating to others, but major of the companies are exited from antibiotic R&D development. Market failure, development cost $1.5 billion per new antibiotics, and clinical trials for antibiotics are especially complex and expensive. इनके solutions क्या होंगे? Solutions क्या रहेंगे? Global innovation fund आना चाहिए, पुश एंड पुल इंसेंटिव्स होने चाहिए जिसमें ग्रांट्स मिलने चाहिए और इनके कॉस्ट को कम करना चाहिए. अदर ऑल्टरनेट्स पे जाना चाहिए. एंटीबायोटिक्स आर नॉट द ओनली सोर्स फॉर इन्फेक्शन क्योर. वी कैन गो फॉर अनदर ऑप्शंस, वी कैन सर्च फॉर अनदर ऑप्शंस जैसे थेरेपी, बैक्टीरियोसेंस, वैक्सीन्स, एंड सर्चिंग फॉर एंटीबायोटिक अल्टरनेटिव्स. Moving to environmental dimensions. 3 environmental dimensions are there: air, water, and environment. How environment can serve as a vehicle and the victim for AMR. Vehicle कैसे काम करता है? Water carry resistant genes and bacteria across borders. Soil absorb antibiotics from agriculture and animal waste, alter microbial communities. Air carry resistant bacteria from livestock farms and wastewater treatment plants. Wildlife or animals act as reservoir and spreader of resistant pathogens across ecosystem. Now, how environment is a victim? हम एक हेल्थ की बात करते हैं कि हमें हमारी हेल्थ को कवर अप करना है, पर सस्टेनेबल डेवलपमेंट क्या कहती है? एनवायरमेंट को भी हेल्थ को कवर अप करते हुए हम ग्रो करेंगे तो वो एनवायरमेंटल हेल्थ रहेगी. Antimicrobial pollutants disrupt soil, essential for ecosystem function. Pharmaceutical effluents in waterways, disrupting water quality. Reduce soil diversity, weakens. अगर soil diversity कम होती है तो food production कम होगा. Health ecosystem is the greatest resource for novel antibiotic discovery. Now, 5 pathways of antimicrobial pollution. Antimicrobial pollution कहाँ से आ रहा है? और यूनाइटेड नेशंस ऑफ एनवायरमेंटल पॉल्यूशन, इन्होंने हमें बताया कि ह्यूमन एक्सक्रीटा अनमेटाबोलाइज्ड जो हमारी बॉडी से एंटीबायोटिक्स निकलते हैं वो सीवेज वाटर में जा रहे हैं, सरफेस वाटर में जा रहे हैं, जो धीरे धीरे सीपिंग हो रही है और एंटीबायोटिक्स एक्यूमुलेट हो रहे हैं हमारे ग्राउंड वाटर में. एनिमल फार्मिंग में जो ह्यूमन एनिमल एक्सक्रीटा है मैन्योर फॉर्म में यूज किया जा रहा है वो, और फर्टिलाइजर्स डू कंसंट्रेट ड्रग्स इन सॉइल एंड रनऑफ्स. फिर फार्मास्यूटिकल मैन्युफैक्चरिंग, एपीआई जो फार्मास्यूटिकल यूनिट से निकल रहा है और वेस्ट वाटर फ्रॉम एंटीबायोटिक प्रोडक्शन कंटेमिनेट लोकल वाटर बॉडीज. हेल्थ केयर फैसिलिटीज, हॉस्पिटल एफ्लुएंट्स carry resistant organisms and antibiotic into municipal water system. Now, climate change accelerates antimicrobial resistance. 1 degree rise, जो antimicrobial resistance develop हो रहा है, हमारे environment का 1 degree rise temperature हुआ है, 1 degree Celsius temperature rise हुआ है, जिसकी वजह से क्या क्या impacts आ रहे हैं? First impact है bacterial growth और replication fast हो गया. वार्मर कंडीशंस में जीन ट्रांसफर रेट्स बढ़ जाते हैं. न्यू क्लाइमेट जोन सपोर्ट पैथोजेंस प्रीवियसली अनेबल टू सर्वाइव. अब जब ट्रैवल हो रहा है, ट्रेड हो रहा है, विद इन कंट्री हो रहा है, इन बिटवीन कंट्रीज हो रहा है, तो जो पैथोजेंस हमारे यहाँ सर्वाइव नहीं करते थे ड्यू टू टेम्परेचर वेरिएशंस, वो अब सर्वाइव करने लगे. फ्लड्स और ड्रॉट्स, फ्लड्स क्या करते हैं? फार्म से, फैसिलिटीज से एंटीबायोटिक रिलीज करते हैं. कहाँ? वाटर बॉडीज में. ड्रॉट्स क्या कर रहे हैं? वाटर बॉडीज श्रिंक हो रही हैं तो वहां पर एंटीमाइक्रोबियल्स कंसंट्रेट कर रहे हैं. फिर वेक्टर-बोर्न डिसीज आर मलेरिया that spread to new regions requiring more antibiotic treatment. So, biodiversity loss. अब बायोडाइवर्सिटी लूज हो रही है. कैसे बायोडाइवर्सिटी लूज हो रही है? हमने डिस्कस किया है कि जैसे ही फील्ड से वाटर रन ऑफ होगा वो क्या लेगा? हमने वहां यूज किया मैन्योर, फर्टिलाइजर्स. जो मैन्योर है वो खाए, मैन्योर निकला है ह्यूमन और एनिमल एक्सक्रीटा से. एनिमल एक्सक्रीटा और ह्यूमन क्या कर रहे हैं? एंटीबायोटिक्स, वहां एंटीबायोटिक्स यूज किया जा रहा है तो कुछ पार्ट एंटीबायोटिक्स का मैन्योर्स में आ रहा है. वो मैन्योर सॉइल की फर्टिलिटी एनहांस करने के लिए यूज किए जा रहे हैं तो वहां एंटीबायोटिक्स आ रहा है. एंटीबायोटिक वहां एक्यूमुलेट होने के बाद जो प्लांट प्रोडक्ट्स हैं उनके अंदर एंटीबायोटिक्स जा रहा है. तो सोइल माइक्रोबियल डाइवर्सिटी चेंज हो रहा है. हेल्दी सोइल्स कंटेन रिच माइक्रोबियल कम्युनिटीज that naturally suppress pathogens, growth, and limited resistance. Loss of natural barriers reduce microbial diversity, weaken soil natural immune system. जो हमारे खुद के natural nitrogen enhancers थे उनकी बायोडाइवर्सिटी कम हो गई है, और जो हमारे रेजिस्टेंट स्ट्रेन्स हैं, माइक्रो ऑर्गेनिज्म रेजिस्टेंट स्ट्रेन्स हैं, उनकी मल्टीप्लिकेशन बढ़ती जा रही है. Pharmaceutical discoveries. Over 70% of the antibiotics come from soil microorganisms. As biodiversity collapses, reservoir for new antibiotics is off. Wildlife reservoirs, terrestrial wildlife, harbor and spread resistant pathogens. Antimicrobial resistance, gene readily transfer between wildlife, domestic animals, and humans. Water. Water is a primary vector for AMR spread. As we have discussed earlier, water कैसे spread कर रहा है AMR को? जितना भी content है, वो water bodies में आ रहा है. Lastly, surge होके, seeps होके, so water is recognized as the primary environmental vector for AMR spread, carrying resistant bacteria genes and across borders. Antibiotics found in major rivers at concentrations that actively select for resistant. वो जो concentration है, वो उस बैक्टीरिया को किल नहीं कर सकता जिसके लिए वो बना हुआ है, लेकिन वो इतना जरूर है कि वो रेजिस्टेंस डेवलप कर लेगा. National antimicrobial resistance plans, action plans rarely address aquatic environment adequately. Aquatic water bodies के लिए कोई भी AMR national action plans act upon नहीं करता. Wash inadequacy enables both infection spread and AMR development. Drug-resistant pathogens in water could trigger future pandemic scale outbreaks. Vipogreen database contains 1,500 wastewater treatment technologies to mitigate AMR. जब भी वाटर को डिस्पोज ऑफ करना है, चाहे किसी भी यूनिट से निकल रहा है, उसको ट्रीट करके फिर वाटर बॉडीज में भेजना चाहिए. Agriculture, the largest driver of global antibiotic use. 75% of the antibiotics have been used globally to administer to animals. First, 27 antimicrobial classes are there. Some of them are last resorted treatments critical for human medicines. 27 antimicrobial classes में से कुछ ड्रग्स तो ऐसी हैं जो लास्ट रिजोर्ट को बिलोंग करती हैं, यानी कि थर्ड लाइन ड्रग को बिलोंग करती हैं. अगर वो हम एनिमल्स को देंगे इन्फेक्शंस ना होने के लिए, तो वो कहीं ना कहीं पैसिवली हमें भी आ रही हैं क्योंकि हम उनके प्रोडक्ट्स यूज कर रहे हैं. जिंक एंड कॉपर एडिटिव्स दिए जाते हैं ताकि वो फीड को एनहांस कर पाए, पर वो भी रेजिस्टेंस डेवलप कर रहे हैं. मैन्योर यूज किया जाता है, एनिमल फेड, एनिमल कंसंट्रेट्स, एंटीमाइक्रोबियल्स इन सॉइल व्हेन यूज्ड एज अ फर्टिलाइजर्स. जो इनका रनवे होता है फार्म्स का, वो वाटरवेज को जाता है, यूज्ड टू इरिगेट फूड क्रॉप्स. ऐसे ही चिकन में एक बैक्टीरिया है साल्मोनेला, वो ग्रो करता जा रहा है, जिससे क्या हो रहा है, हमारे ह्यूमंस में, हम में रेजिस्टेंस डेवलप हो रहा है. FAO launched 10-year initiative to reduce antimicrobial need in agri-food systems. जो FAO है, अब वो ये इनिशिएटिव ले रहा है कि अगले टाइम पे हमें मैन्योर्स को एंटीबायोटिक यूज कम करना है. किसमें? एनिमल्स में. अगर एंटीबायोटिक यूज एनिमल्स में कम होगा, मैन्योर्स एंटीबायोटिक्स कम कॉन्सेंट्रेट्स में रहेगा, वहां पर रेजिस्टेंस कम डेवलप होगा, तो हम फ्यूचर में इसको रिड्यूस करने के लिए काम कर सकते हैं, या हमारे जो एक्शंस हैं वो इम्प्लीमेंट होते हुए हमें दिखेंगे डाटा में. फार्मास्यूटिकल मैन्युफैक्चरिंग अ क्रिटिकल Pharmaceutical manufacturing, a critical AMR source. Pharmaceutical manufacturing units कैसे AMR को respond करती हैं? Pharmaceutical and chemical production is one of the 3 main sources of global AMR spread. कैसे? Pharmaceuticals में API यूज किए जाते हैं. जब उनको डिस्पोज ऑफ किया जाता है, वेस्ट वाटर often inadequately treated होता है और वो लोकल वाटर बॉडीज को कंटेमिनेट करता है. Manufacturing hubs in China and India are Hyderabad and Patanjali are documented at high-risk sites. WHO and UNEP jointly issued guidance on wastewater management for antibiotic manufacturing. In 2018, AMR Industry Alliance established common antibiotic manufacturing framework. Updated antibiotic manufacturing standards set safe for environmental concentration limits. Environment में अगर एंटीबायोटिक कंसंट्रेट्स कम होंगे तभी हम इस स्टेप को आगे कर सकते हैं. Davos Compact 2025 is there. G7, G20, G77 governments lead an objective that AMR 2025 will concentrate on public-private collaborations. AMR के लिए अवेयरनेस जनरेट करने के लिए पब्लिक और प्राइवेट कोलैबोरेशंस का होना जरूरी है ताकि जो रूल्स रेगुलेशंस बन रहे हैं उनका इम्प्लीमेंटेशन हो सके. जूनोटिक पाथवेज, AMR कैसे ट्रांसफर करता है एनिमल से ह्यूमन को? डायरेक्ट कॉन्टेक्ट, फूडबोर्न, एनवायरमेंटल एंड ऑक्यूपेशनल. डायरेक्ट कॉन्टेक्ट में कैसे? पीपल वर्किंग इन एंड लिविंग नियर लाइवस्टॉक फैसिलिटीज, farm workers, veterinarians have disproportionately high AMR exposure. Next, foodborne. Foodborne जो food हमें animal से मिलता है. Consumption of meat, poultry, eggs, fish carrying resistant pathogens, salmonella, transfer resistance genes to human gut bacteria. Next is environmental. Soil, water से जो हमें मिल रहा है कैसे? Antibiotic resistant genes from animal waste that enters into soil and water, eventually reaching human populations through agriculture and drinking water. Occupational. Processing plant workers, slaughterhouse employees, aquaculture workers are at high occupational exposure risk to AMR. One Health approach. One Health approach cover up One Health human, One Health animal, and one is environment. Now connecting AMR to sustainable development. Sustainable development कैसे AMR अगर ये दोनों साथ में चलते हैं हमें फ्यूचर में एक पॉजिटिव इम्पैक्ट दिखे. SDG सस्टेनेबल डेवलपमेंट गोल्स, अगर AMR इसी तरीके से बढ़ता रहा तो हम SDG अचीव नहीं कर पाएंगे by 2030. The global One Health Index for AMR stands at 38.45 out of 100, based on 146 countries, threatening 7 of the 17 SDG. 17 Sustainable Development Goals जो डायरेक्टली और इनडायरेक्टली इम्पेक्ट कर रहे हैं 7 SDGs को. 7 SDGs क्या क्या है? First is poverty, SDG 1. Second is food security. Third is health, SDG 6 for clean water. SDG 8 economic growth. SDG 10 inequalities. And SDG 13 climate action. First, poverty. Poverty होने की वजह से wash attain नहीं कर पाते. Wash is water, poor water, sanitation and hygiene. तो लो मिडिल इनकम कंट्रीज पॉवर्टी की तरफ जा रहे हैं जिसकी वजह से हेल्थ केयर कॉस्ट बढ़ रहे हैं, प्रोडक्टिविटी डाउन जा रही है. फर्स्ट. सेकेंड SDG इज फूड सिक्योरिटी. पॉपुलेशन बढ़ रहा है, पॉपुलेशन बढ़ने की वजह से फूड डिमांड बढ़ती है. फूड डिमांड को कंप्लीट करने के लिए हमें क्या करना है? एनिमल्स को और क्रॉप्स को इन्फेक्शन फ्री रखना है, जिसकी वजह से एंटीबायोटिक्स ओवर यूज कर रहे हैं. एंटीबायोटिक्स ओवर यूज कर रहे हैं तो SDG 2 हैम्पर हो रहा है. नेक्स्ट SDG 3 जो हेल्थ को फोकस करता है. SDG 3 में 8 मेन टारगेट्स ऐसे हैं जो डायरेक्टली और इनडायरेक्टली AMR को हैम्पर कर रहे हैं. इसको हम नेक्स्ट स्लाइड में डिस्कस करेंगे. SDG 6 water, clean water for drinking purposes. Water contaminated with antimicrobials. अब जितना भी वाटर से जो एंटीमाइक्रोबियल कंटेमिनेटेड आ रहा है उसके अंदर रेजिस्टेंस जीन्स आ रहे हैं, वो क्या कर रहा है? हमारे SDG 6 को हैम्पर कर रहा है. या SDG 6 इम्प्लीमेंट ही नहीं हो पा रहा क्योंकि हमारे पास एडिक्वेट क्लीन वाटर है ही नहीं ड्रिंकिंग पर्पसेस के लिए. इकोनॉमिक ग्रोथ, AMR cost, जब AMR cost billions in lost productivity and increased healthcare expenditure annually. SDG 10 for inequalities. Inequalities in which terms? Gender inequalities. UTIs are more prone to females. Surgeries more prone to females. So antibiotics have been extensively used by women. तो उनको लिमिट करने के लिए या अवेयरनेस देने के लिए हमें अवेयरनेस प्रोग्राम सेटल करने चाहिए. SDG 13 क्लाइमेट एक्शन. क्लाइमेट एक्शन पहले डिस्कस किया था. 1 डिग्री राइज हुआ है क्लाइमेट. अगर 1 डिग्री सेल्सियस राइज होने की वजह से क्या हुआ? एंटी माइक्रोबियल ग्रोथ बढ़ गई है, माइक्रोबियल रेजिस्टेंस जीन्स बढ़ गए हैं. 1 डिग्री राइज से जीन म्यूटेशंस के चांसेस बढ़ जाते हैं. और जो ट्रेड ऑफ होता है इन बिटवीन कंट्रीज एंड इन कंट्रीज, उसमें रेजिस्टेंस जीन्स का ट्रांसफर हो जाता है. तो SDG 13 भी हैम्पर हो रहा है. नाउ फोकसिंग ऑन SDG 3, जिसमें 8 टारगेट्स हैम्पर हो गए. 8 टारगेट्स में 3.1 मैटरनल मोर्टेलिटी, एंटीमाइक्रोबियल रेजिस्टेंस. अब यहाँ जेंडर इनइक्वालिटी भी आ जाएगा कि ह्यूमन फीमेल में ज्यादा एंटीबायोटिक्स यूज किए जाते हैं with reference to males. Maternal mortality. Antimicrobial makes infections during pregnancy, delivery hardest to treat, higher maternal mortality. 3.2. These are the targets of SDG 3 and how they are hampering sustainable development. 3.2 deals with child mortality, drug-resistant pneumonia and diarrhea, preventable child death increasing. 3.2 deals with communicable diseases. Communicable diseases, HIV, tuberculosis, sexually transmitted disease. AMR reduces effectiveness of essential treatment regimens. 3.24 deals with non-communicable diseases. Non-communicable diseases, as we have discussed, immunocompromised patients, that is cancer, transplants, surgery. These times, heavy antibiotic doses have been used for prevention of infections. 3.6, road injuries. Road injuries, post-trauma infections, increasingly resistant, longer recovery, and higher mortality. 3.7, reproductive health. Drug-resistant sexually transmitted infections affect maternal and reproductive health outcomes. 3.8, due to poverty, universal health coverage. Universal health coverage costs have been increasing. AMR increases cost and complexity of care. Access to treatment shrinks. 3.B, that covers research and medicines. Antibiotics के ऊपर research continued रहनी चाहिए और new medicines market में आते रहने चाहिए. लेकिन उसके लिए grants sufficient होने चाहिए और initiatives होना चाहिए कि अब clinical trials cost effective रहने चाहिए. Circular health embedding AMR in SDG roadmap. अगर SDG को AMR के साथ कनेक्ट किया जाए और इन चीजों को कवर करते हुए हम साइमल्टेनियसली 2 गोल्स अचीव कर रहे हैं. एंटीमाइक्रोबियल रेजिस्टेंस कम हो रहा है और SDG के गोल्स अचीव हो रहे हैं. Circular health proposes that fighting AMR must be integrated across all SDGs, not just SDG 3. SDG 3 deals with health. To achieve a convergent multi-stakeholder response. SDG 1, no poverty. Poverty नहीं होगी तो अगर poverty नहीं होगी तो health care की जो cost है वो one individual bear कर पाएगा. SDG 2, zero hunger. Zero hunger, अब इसमें हमें rational use of antibiotics, हम ये नहीं कहेंगे antibiotics use नहीं करना infection free करने के लिए animals को, but rational use of antibiotics होना चाहिए जिसकी वजह से sustainable farming रहे. SDG 4, quality education. AMR एंटीमाइक्रोबियल रेजिस्टेंस कैसे डेवलप हो रहा है, क्या इसके इफेक्ट्स हैं, कैसे इसको रिड्यूस करना चाहिए, अगर एंटीबायोटिक्स यूज कर रहे हो तो कैसे यूज किए जाने चाहिए, इन सब के लिए अवेयरनेस प्रोग्राम स्टार्ट किए जाने चाहिए एट ग्राउंड लेवल। ग्राउंड लेवल स्कूल से स्टार्ट होता है। SDG 9 इनोवेशन, नए स्टार्टअप स्टार्ट किए जाने चाहिए जो AMR को सपोर्ट करें। एंटीमाइक्रोबियल वेस्ट प्रोसेसिंग इन इंफ्रास्ट्रक्चर टारगेट्स। SDG 12 रिस्पॉन्सिबल कंजप्शन। रिस्पॉन्सिबल कंजप्शन इसमें क्या है कि जो फार्मास्यूटिकल यूनिट्स हैं जो वेस्ट निकाल रही हैं, जो एफ्लुएंट्स निकाल रही हैं, वो वाटर बॉडीज में डायरेक्टली ना डालें, उनको प्रॉपर ट्रीट करके फिर उनको डिस्पोज ऑफ किया जाना चाहिए। पब्लिक AMR अवेयरनेस आना चाहिए यहाँ पर, उसके लिए हमें कैंपेन्स ऑर्गेनाइज करने चाहिए। फीमेल्स को इन्वॉल्व करना चाहिए क्योंकि फीमेल्स होम मेकर्स होती हैं, वो डिसाइड कर पाएंगे, उनको पता होगा कि अगर 5 डे का मेडिकेशन है तो 5 डे कंप्लीट किए जाने चाहिए। डोज जो है वो उतनी ही देनी चाहिए, कम नहीं देनी चाहिए। इमोशनली हमें ये नहीं सोचना चाहिए कि हम ठीक हो गए, अब दवाई की जरूरत नहीं है, या ये दवाई गर्म कर रही है, इसको नहीं देना। तो इसके लिए पब्लिक AMR अवेयरनेस रिक्वायर्ड है, जिसके अंदर फीमेल इनिशिएटिव ज्यादा होना चाहिए। SDG 16 स्ट्रॉन्ग इंस्टीट्यूशंस, जैसे एंटी करप्शन इंस्टीट्यूशंस बने हुए हैं, ऐसे एंटीबायोटिक स्टीवर्डशिप भी होनी चाहिए। जो पेपर्स पे इतना सारा लिखा हुआ है कि SDG गोल्स बन रहे हैं, या फिर हमारे नए नेशनल ग्लोबल एक्शन प्लान्स बने, ग्लोबल एक्शन प्लान्स के बाद नेशनल एक्शन प्लान्स भी बने, और नेशनल एक्शन प्लान्स के बाद मैम ने डिस्कस किया स्टेट एक्शन प्लान्स भी बने, वो हमें कहीं इम्प्लीमेंट होते हुए दिखते नहीं, वो सिर्फ पेपर्स तक रह जाते हैं। उनको इम्प्लीमेंट करने के लिए एक ऑर्गेनाइजेशन बने जो इनको लुक अपॉन करे कि जो बन रहा है, जो पेपर पे आ रहा है, वो रूल्स एंड रेगुलेशंस इम्प्लीमेंट हो रहे हैं, और हमें रिस्पॉन्सिबल सिटीजन्स की तरह काम भी करना चाहिए। SDG 17 ग्लोबल पार्टनरशिप। ग्लोबल पार्टनरशिप, अब अगर टेक्नोलॉजी ट्रांसफर होगा, सर्वेलेंस सिस्टम ट्रांसफर होगा, रिसर्च कोऑपरेशन आएगा, तो हम AMR से डील कर पाएंगे। वो विद इन कंट्री पॉसिबल नहीं होगा, अगर ग्लोबली इसको किया जाएगा, अलग अलग कंट्रीज पार्टिसिपेट करेंगे और टेक्नोलॉजी ट्रांसफर करेंगे, तो हम AMR को कॉम्बैट कर पाएंगे। WHO ग्लोबल एक्शन प्लान, ये 2015 में GAP दिया था WHO ने, जिसमें पांच पर्सपेक्टिव्स डील किए गए थे: अवेयरनेस, सर्वेलेंस, प्रिवेंशन, ऑप्टिमल यूज एंड इन्वेस्टमेंट। फर्स्ट इज अवेयरनेस। अवेयरनेस इंप्रूव करने के लिए हमें कम्युनिकेशंस आने चाहिए, एजुकेशन होना चाहिए और ट्रेनिंग। ये सब कैंपेन्स करेंगे, अवेयरनेस प्रोग्राम्स करेंगे, या नुक्कड़ नाटक कर सकते हैं। जब किसी को पर्सनली इम्पैक्ट करना है तो नाटक एक बड़ा पार्ट प्ले करते हैं किसी चीज को दिखाने के लिए, और ये टाइम है AMR के लिए शो करने के लिए कि AMR हमारे लिए फ्यूचर में कितना बड़ा थ्रेट है, और उससे हम ग्राउंड लेवल पे कैसे डील करेंगे, इंडिविजुअल लेवल पे कैसे डील करेंगे। सर्वेलेंस, strengthen the knowledge and evidence base through surveillance and research. प्रॉपर FAQs जनरेट किए जाने चाहिए, रिसर्च आपके सर्वेलेंस होने चाहिए कि क्या इम्प्लीमेंट किया जा रहा है, क्या फेस कर रहे हैं हम, क्या प्रॉब्लम्स फेस कर रहे हैं, और हमें क्या गाइडलाइंस फॉलो करनी चाहिए, डाटा कहाँ से मिलेगा। प्रिवेंशंस, रिड्यूस इंसिडेंस ऑफ इन्फेक्शंस। इंसिडेंस ऑफ इन्फेक्शंस को रिड्यूस कैसे करेंगे, जब हमारा सैनिटेशन, हाइजीन एंड इन्फेक्शन प्रिवेंशन होगा। सैनिटेशन और हाइजीन के ऊपर ध्यान रखते हैं तो इन्फेक्शन के चांसेस कम हो जाते हैं। पॉवर्टी नहीं होगा तो हम अपनी सैनिटेशन मेंटेन कर पाएंगे। ऑप्टिमाइज यूज rather than misuse, overuse, abuse of antibiotics, we should optimize the use of antibiotics in human and animal health. रैशनल यूज होगा तो एंटीबायोटिक्स इन्फेक्शंस को क्योर करेंगे. अगर इसका यूज ज्यादा होगा, ओवर यूज होगा, तो लास्टली ये हमें ही हैम्पर करने वाले हैं, हमें ही रेजिस्टेंस माइक्रो ऑर्गेनिजम्स ट्रांसफर करने वाले हैं. इन्वेस्टमेंट किस में करें? फ्यूचर में हम इन्वेस्टमेंट सस्टेनेबल डेवलपमेंट के लिए नई मेडिसिन आनी चाहिए, डायग्नोस्टिक पैरामीटर्स रैपिड होने चाहिए. अगर हम कल्चरिंग की बात करें तो 3 दिन में कल्चर रिपोर्ट आती है, उसके डायग्नोस्टिक न्यू होने चाहिए. क्वाड्रिपार्टाइट ग्लोबल AMR गवर्नेंस, ये 4 ऑर्गेनाइजेशंस हैं जो एक दूसरे के साथ मिलके काम करते हैं. और WHO जो ह्यूमन हेल्थ के लिए काम कर रही है, नेशनल एक्शन प्लान्स बना रही है, ग्लास सर्वेलेंस सिस्टम बना रही है, और हेल्थ AMR रिस्पॉन्स. FAO फूड एंड एग्रीकल्चर ऑर्गेनाइजेशन जो आपके लाइफ स्टॉक को डील करती है, चाहे वो फूड है, एग्रीकल्चर है या मरीन है, एक्वाकल्चर सेक्टर्स है. अभी पहले डिस्कस किया था, एक्वाकल्चर्स के लिए कहीं भी नेशनल एक्शन प्लान्स में मेंशन नहीं है कि क्या गाइडलाइंस फॉलो की जानी चाहिए. वर्ल्ड ऑर्गेनाइजेशन फॉर एनिमल हेल्थ सेट वेटरनरी स्टैंडर्ड्स, वो वेटरनरी स्टैंडर्ड सेट करें कि कौन से एंटीमाइक्रोबियल्स यूज किए जाने चाहिए एनिमल्स में. रादर देन टू यूज लास्ट रिजोर्ट एंटीबायोटिक्स, वी मस्ट यूज ऑल्टरनेट्स or optimize use. UNEP is United Nations Environmental Program that has been joined in 2022, leads to the environmental dimensions of AMR and pharmaceutical pollution. ये फैक्टर्स को गवर्न करता है कि वेस्ट कैसे मैनेज किया जा रहा है, चाहे वो फार्मास्यूटिकल से है, चाहे वो केमिकल से है, चाहे वो फील्ड से है. सोइल की फर्टिलिटी कैसे मैनेज की जाएगी और फार्मास्यूटिकल पॉल्यूशन को कैसे कंट्रोल किया जाएगा. UN General Assembly high level meeting on AMR. This has been conducted in September 2024 for only the 4th time in history. United Nations ने 4th time पूरी हिस्ट्री में 4 मीटिंग्स की हैं जो सिर्फ एंटीमाइक्रोबियल रेजिस्टेंस के ऊपर मीटिंग करता है. United Nations General Assembly convened a high-level meeting on a specific health topic, that is antimicrobial resistance. अगर वो इस पर मीटिंग करता है तो इसका मतलब है ये हाईली थ्रेटेंड ग्लोबल थ्रेट है. की पॉलिटिकल डिक्लेरेशन कमिटमेंट्स क्या थे? Reduce estimated 4.9 million AMR associated deaths annually by 10% by 2030. Establish independent panels on evidence for action against AMR. Prevent and address discharge of antimicrobials from the environment. Catalyze actions to address key sources of antimicrobial pollution globally. Research and knowledge on environmental dimension should be increased. And quadruped coordination governs at all levels. जो 4 अथॉरिटीज हैं वो आपस में कोऑर्डिनेट करके काम करें ताकि इन सस्टेनेबल डेवलपमेंट गोल्स को हम अचीव कर पाए. एनवायरमेंट को ध्यान रखें, अपनी हेल्थ का ध्यान रखें और एनिमल्स की हेल्थ का ध्यान रखें. सो टुडे there is a framework in which 10-20-30 we should achieve. What is 10-20-30? 10% reduction in AMR attributable deaths. AMR से जो डेथ हो रही है उनका 10% रिडक्शन चाहिए एनुअली. दूसरा टारगेट 20% रिडक्शन इन इनएप्रोप्रिएट ह्यूमन एंटीबायोटिक यूज बाय 2030. 20% रिडक्शन किसका चाहिए? एंटीबायोटिक यूज का. वो कैसे होगा? रैशनल और ऑप्टिमाइज यूज ऑफ एंटीबायोटिक्स. 30% रिडक्शन होना चाहिए एंटीबायोटिक यूज इन एनिमल्स. उसके लिए वेटनरी डाटा चाहिए. वेटनरी को गाइडलाइंस बनानी पड़ेंगी कि कौन सी एंटीबायोटिक्स कब दी जानी चाहिए, कितनी दी जानी चाहिए. ओवर यूज वहां पर भी होना चाहिए, ओवर यूज वहां पर भी लिमिटेड होना चाहिए. ग्लोबल AMR सर्वेलेंस नोइंग द एनिमी। अब हमारी जो ऑर्गेनाइजेशंस हैं वर्ल्ड लेवल पे, उन्हें पता है कि AMR फ्यूचर में एक थ्रेट है और उसको कवर करने के लिए हमें काम कैसे करना पड़ेगा। WHO ग्लास के थ्रू काम कर रहा है, FAO इन्फॉर्म से कर रहा है, वोहा वाइस से कर रहा है, क्वाड्रपाइड वा से कर रहा है और WHO ग्लास AMR कम्युनिटी से कर रहा है। Gender dimensions of AMR. What are gender dimensions of AMR? Females are there. Worldwide, primary role in acquiring, administering, and disposing of antibiotics. Nurses play that role. Nurses, usually females, play a part in the nursing, and they are acquiring, administering, and disposing antibiotics to patients. Women are prescribed more antibiotics than men in primary care settings globally due to high UTIs and post-surgery. Women make 70% of healthcare workforce. This includes nurses, doctors, and frontline healthcare workers. Reproductive health infections, UTIs and STIs, frequently treated with antibiotics. Women at high exposure of antibiotics. WHO AMR mitigation strategies with gender focus are more people-centered and effective. इसके लिए recommended actions क्या रहेंगे? Develop gender-tailored AMR awareness campaigns. Female-oriented campaigns होने चाहिए. Building on existing HPV prevention, human papilloma virus की preventions के लिए campaigns होने चाहिए to integrate AMR messaging. Third, empower women in healthcare leadership to drive stewardship programs. अगर women acknowledged होगी, उसे पता होगा एंटीबायोटिक्स कैसे यूज किए जाने चाहिए, तो वो मिसयूज नहीं होने देगी. उनके साइड इफेक्ट्स क्या हैं, लॉन्ग टर्म इफेक्ट्स क्या हैं, तो women's do play a vital role और वो यहाँ ठीक करेंगे. Include gender-specific antibiotic disposal guidance in public health programs. हमें antibiotics कौन से यूज किए जाने चाहिए, कैसे यूज किए जाने चाहिए, जेंडर स्पेसिफिक कौन से होते हैं, विदाउट डॉक्टर प्रिस्क्रिप्शन हमें कोई भी एंटीबायोटिक नहीं लेना चाहिए, ये सब ध्यान रखना. Track antimicrobial use by gender to identify patterns and target intervention. Antimicrobial stewardship programs. Antimicrobial stewardship, what does the antimicrobial stewardship refers to? It is a coordinated intervention designed to improve and measure the appropriate use of antibiotics by promoting selection of optimal regimen. कि मेडिसिन कितनी डोजिंग में दी जानी चाहिए, उसका सिलेक्शन ऑप्टिमल रेजिमेंट कहलाता है. कितने टाइम के लिए दिया जाना चाहिए, वो भी ऑप्टिमल रेजिमेंट में आता है. हॉस्पिटल इज multidisciplinary teams ensure correct antibiotic selection, dose, and duration in clinical settings. Community programs, public education campaigns, prescribing guidelines, and pharmacy controls reduce inappropriate community programs, veterinary stewardship, guidelines for rational antibiotic use in companion animals, livestock, and aquaculture. Digital tools. Prescriptions आजकल ऑनलाइन हो गई हैं. प्रिस्क्रिप्शंस अगर ऑनलाइन है तो आपकी मेडिसिन होम पे आती है. वहां मुझे लगता है एक कि आपका अगर प्रिस्क्रिप्शन 5 days का है तो वो मेडिसिन दोबारा नहीं देनी चाहिए या हमें मिलनी नहीं चाहिए, उसके ऊपर लिमिटेशन आना चाहिए. क्योंकि इसमें क्या है, अगर लॉन्ग टर्म मेडिकेशंस हैं, डायबिटीज का मेडिकेशन है, आपका शुगर का मेडिकेशन, ये बीपी का मेडिकेशन है, इनके लिए लॉन्ग टर्म मेडिकेशन रिक्वायर्ड है और वो मिलनी भी चाहिए डिजिटली. लेकिन अगर इन्फेक्शंस के लिए एंटीबायोटिक्स रेफर किए जा रहे हैं तो वो 5D की डोजिंग में ही आना चाहिए, एज स्पेसिफिक ही आना चाहिए, और दोबारा अगर उसको ऑर्डर लगाया जाए तो वहां लिमिटेशन आना चाहिए। ये चीज मैंने देखी है कि हम ऑर्डर प्लेस कर सकते हैं, रिपीटेटिव यूज कर सकते हैं और नंबर ऑफ टाइम्स हम ऑर्डर प्लेस कर सकते हैं। उसके लिए डिजिटली इसको लिमिट करना चाहिए। एजुकेशन integrating stewardship and about AMR in medical, nursing, pharmacy, and veterinary curricula globally. Sorry for the interruptions. What are the alternatives, treatment strategies beyond antibiotics? First is bacteriophage therapy. Second is vaccines, probiotics, monoclonal antibodies, antimicrobial peptides, and biofilm disruptors. First is bacteriophage therapy. Viruses that infect and kill specific bacteria are highly targeted with no effect on beneficial microbes. तो यहाँ जब टारगेटेड मेडिसिन यूज की जाएंगी एंटीवायरल तो वो ज्यादा इफेक्ट करेंगे। वैक्सीन जो इन्फेक्शंस को प्रिवेंट करने के लिए हमारा वैक्सीन होता है वो टाइमली लिया जाना चाहिए। प्रिवेंट इन्फेक्शंस, reduce antibiotic demands. COVID-19 showed vaccines can reduce inappropriate antibiotic prescribing. Probiotics restore healthy microbe. अगर हमारा माइक्रोबैक्टीरियल गट हेल्दी रहेगा, वहां का फोना एक्टिव रहेगा तो हमें इन्फेक्शंस कम होंगे, जिससे प्रोबायोटिक्स हेल्प करते हैं। Probiotics help in restoring health microbiome balance, competitive exclusion of resistant pathogens in gut and beyond. Monoclonal antibodies, MAPs, targeted immune proteins that neutralize specific bacterial toxins or surface antigens. MAPs काम करेंगी specific target पर. Antimicrobial peptides, as ma'am have been discussed, natural or synthetic peptides from human, plant, insect source with broad spectrum activity पर सर्च होना चाहिए. Biofilm disruptors, novel agents targeting the protective biofilm that shield resistant bacteria from antibiotics. Now, what are the future perspectives? That is technology and innovation in the AMR fight. First is AI. A number of tools have been developed और उसमें हमें रेजिस्टेंस जीन्स को आइडेंटिफाई करना चाहिए, ड्रग डिस्कवरी टारगेट्स को आइडेंटिफाई कर सकते हैं, रेजिस्टेंस इमर्जेंस पैटर्न्स को आइडेंटिफाई कर सकते हैं। जो प्रायर डाटा है उसको स्टडी करके हम अगली पॉसिबिलिटी बता सकते हैं, प्रोबेबिलिटी ऑफ इमर्जेंस, क्योंकि डिसीज इन्फेक्शंस इमर्ज होने के बाद एंटीबायोटिक्स लिए फिर वो री इमर्ज हो रही है, तो पैटर्न्स होते हैं डिसीज ओरिएंटेशन के, वो हम एआई से स्टडी कर सकते हैं। रैपिड डायग्नोस्टिक, पॉइंट ऑफ केयर टेस्ट have identified causative agent and its resistance profile occur within 48 to 72 hours. कल्चरिंग में 48 to 72 hours लगते हैं, जिसकी वजह से विदाउट डायग्नोस्टिक हम एंटीबायोटिक्स पे चले जाते हैं। तो जो डायग्नोस्टिक पैरामीटर्स हैं उनको रैपिड में कन्वर्ट करना है। रैपिड डायग्नोस्टिक होगा तो रेशनल यूज ऑफ एंटीबायोटिक्स हो पाएगा। जीनोमिक सर्वेलेंस, whole genome sequencing of resistant strains tracks spread in real time, enabling outbreak detection and global antibiotic mapping. कि किस तरीके से डेवलप हो रहा है, कहाँ जा रहा है, कितना जा रहा है। जब जीनोम मैपिंग हो जाएगी तो ये सब चीजें हम एनालाइज कर पाएंगे। एनालिटिकल मेथड्स को बढ़ाना है जीन लेवल पे, इसे जीनोमिक सर्वेलेंस कहेंगे। डिजिटल हेल्थ prescription tracking system should be monitored. Antibiotic stewardship apps should be developed. Clinical decisions support tools reducing inappropriate prescribing at point of care should be taken care of by medical prescribers. Trade is central to achieving AMR related SDGs. A case study एनालिसिस कि यहाँ पर एक केस स्टडी बताती है कि इन चीजों को कैसे हम कंट्रोल कर सकते हैं, फ्यूचर में कैसे अचीव कर सकते हैं। हेल्थ गुड्स ट्रेड्स, जो हेल्थ गुड्स हैं, चाहे वो एंटीबायोटिक्स हैं, डायग्नोस्टिक्स हैं, वैक्सीन हैं, पीपीई किट्स हैं, वो ऑल ओवर वर्ल्ड ग्लोबली अवेलेबल होने चाहिए। मेडिकल इंटेलेक्ट ट्रेड, जो मेडिकल फैसिलिटीज दूसरे कंट्रीज में, वो लो मिडिल इनकम कंट्रीज में भी आने चाहिए। The movement of trained professionals, researchers, and experts drives capacity building in low-middle income countries. Technology transfer होना चाहिए। जो SDG 17.7 कहता है, वो ये कहता है genomics, diagnostics, stewardship सॉफ्टवेयर जनरेट करने चाहिए जो AMR relevant technologies को डील करेंगे। AMR को जो डील करने वाले हैं, उन genomics, diagnostic और stewardship की तरफ काम करा जाना चाहिए। डाटा शेयरिंग, ग्लोबल पैथोजन सर्वेलेंस, डाटा शेयरिंग प्लेटफॉर्म्स enable science-based global responses. Regulatory harmonization. SPS TBT agreements provide legal basis for the international antibiotic standards. National action plans. 170 countries ने national action plans बनाए थे AMR के ऊपर, लेकिन नेग्लिजिबल इम्प्लीमेंटेशन है एग्रीकल्चर में, इंडस्ट्री सेक्टर में, इन लो मिडिल इनकम कंट्रीज। तो नेशनल एक्शन प्लान्स पेपर की बजाय एनफोर्समेंट में लाने की जरूरत है। ऐसी क्या चीज है जो इनको लिमिट करती है कि ये एनफोर्स नहीं हो पा रहे? फर्स्ट है फंडिंग गैप, सेक्टर कवरेज, मॉनिटरिंग गैप, कोऑर्डिनेशन गैप। फंडिंग गैप, हाई कॉस्ट होने की वजह से लो मिडिल इनकम कंट्रीज के पास उतना कॉस्ट नहीं है, फंड नहीं है, जिसकी वजह से वो डेडिकेटेडली AMR फंडिंग पे काम कर सके। सेक्टर कवरेज, हॉस्पिटल्स सेक्टर हैज प्रोटोकॉल्स, पर एग्रीकल्चर, इंडस्ट्री और रिसर्च सेक्टर्स अभी भी रिक्वायर कर रहे हैं कि हमें फंडिंग चाहिए कि हम इतना काम करें कि वो इम्प्लीमेंटेशन दिखे। मॉनिटरिंग गैप, सर्वेलेंस होना चाहिए, वॉलेंट्री सर्वेलेंस होना चाहिए, सर्वेलेंस कैंपेन्स होने चाहिए कि कितना इम्प्लीमेंट किया जा रहा है। कोऑर्डिनेशन गैप, सोइल मिनिस्ट्रीज, हेल्थ, एग्रीकल्चरल, एनवायरमेंट मिनिस्ट्रीज अगर कोऑर्डिनेशन में काम करेंगी तो AMR पे रिस्पॉन्स हमें दिखेगा, बट दे रेयरली कोऑर्डिनेट इफेक्टिवली। AMR in aquaculture, SDG 14 is there. SDG 14 क्या कहता है? मरीन इकोसिस्टम और एक्वाकल्चर इकोसिस्टम को अगर हम कंट्रोल कर लेते हैं, एक्वाकल्चर क्यों आ रहा है? क्योंकि माइक्रो नैनो प्लास्टिक्स आर देयर इन मरीन वाटर, एंड नाउ वी आर सेइंग AMR antibiotics are there in water. Together, plastics, nanoplastics, and antibiotics are making it unsafe for consumption. इसके लिए क्या रिक्वायर्ड है? वेस्ट वाटर कैसे जाना चाहिए, कैसे उसकी स्क्रीनिंग होनी चाहिए, एक्वाकल्चर में कैसे होगा, और जो मरीन डेब्रिस है उसकी डीलिंग कैसे होगी। एक्वाकल्चर एफ्लुएंट वाटर वंस रिलीज्ड इनटू द एनवायरनमेंट अफेक्ट सराउंडिंग इकोसिस्टम, फिर वो मरीन लाइफ को भी अफेक्ट करता है, आपकी ओशन लाइफ को भी अफेक्ट करता है, आगे आएंगे तो हमारी ह्यूमन को भी इफेक्ट कर रहा है, एनिमल्स को भी इफेक्ट कर रहा है। टोटली वो पूरे इकोसिस्टम को बैलेंस नहीं होने देगा, और जब तक इकोसिस्टम बैलेंस नहीं होगा हम इस क्राइसिस से बाहर नहीं आ सकते। WHO SDG Indicator 14 framework expansion need explicitly address AMR in fisheries and aquaculture management. AMR and life on land. अब मरीन और एक्वाकल्चर में SDG 14 डील करता है, SDG 15 कह रहा है जो टेरेस्ट्रियल लैंड एनिमल्स हैं, जो लैंड पे रह रहे हैं, उनके साथ कैसे हैंडलिंग होगी। सबसे पहले टेरेस्ट्रियल वाइल्ड लाइफ हार्बर्स, वाइल्ड लाइफ को रिजर्वायर की तरह कैप करें, उनको अगर मेंटेन करके रखेंगे तो पॉजिटिव फीडबैक हमारे पास आएगा। इकोसिस्टम सर्विसेज एट रिस्क, जो सोयल का माइक्रोबायोम है उसको मेंटेन करना पड़ेगा, either in the form of nutrient cycle, carbon storage, decomposition and others. फिर नेचुरल हैबिटेट लॉस जो वाइल्ड एनिमल्स हैं, फॉरेस्ट खत्म हो रहा है जिसकी वजह से नेचुरल हैबिटेट लूज कर रहे हैं एनिमल्स, उनको रिटेन करना चाहिए, रीगेन करना चाहिए, तो एनक्रोचमेंट को रोकना चाहिए, ब्रीचिंग को रोकना चाहिए। एनक्रोचमेंट ऑन वाइल्ड habitats increases human-animal contact and likelihood of resistant zoonotic pathogens spillover. Monitoring plans, ये सब चीजें हो रही हैं टेरेस्ट्रियल पे, सोयल की क्वालिटी मेंटेन हो रही है, एनवायरमेंटल का टेक केयर हो रहा है, इन सब के ऊपर मॉनिटरिंग रिक्वायर्ड है। तो डेवलपिंग AMR मॉनिटरिंग इन लोकल वाइल्ड लाइफ पॉपुलेशंस, species accumulation potential varies enormously. These are the references I have been used for gathering data. Thank you.
Thank you very much, ma'am.
Thank you, sir.
बहुत ही अच्छे से आपने सारी चीज एक्सप्लेन करी इन हिंदी, इंग्लिश, मतलब सारा बहुत अच्छे से समझ में आया। जशन मैडम, प्लीज कंटिन्यू।
As we move towards the conclusion of the seminar, I would like to invite Dr. Anjali ma'am to kindly deliver the vote of thanks. Ma'am, may I request you to please present the vote of thanks?
Okay, ma'am, thank you so much. First of all, I would like to thank Dr. Rupal Mittal ma'am. It was really enlightening session. It was really wonderful, ma'am.
Thank you, ma'am.
As we come to the end of this insightful online national seminar on antimicrobial resistance, a silent global pandemic, organized by IPGA Women Forum in collaboration with Guru Gobind Singh College of Pharmacy, it is my profound privilege to propose the vote of thanks. First and the foremost, I would like to express our sincere gratitude to our esteemed speakers, Dr. Avneet Saini and Dr. Rupal Mittal ma'am, for sharing their valuable knowledge and the insights on such an important global health issue. Your expertise has truly enlightened all the participants and inspired us to understand the seriousness of the antimicrobial resistance. I would like to extend our heartfelt thanks to Professor Manju Singh ma'am, the chairperson of IPGA Women Forum, and Professor Dr. Vandana Garg ma'am, the co-chairperson of IPGA Women Forum, for their constant guidance, encouragement, and support in making the seminar successful. My sincere appreciation goes to our organizing secretaries, Dr. Geeta Deswal ma'am and Dr. Neelam Sharma ma'am, for their dedicated efforts in planning and organizing the event smoothly. I would also express our heartfelt gratitude to Dr. Sailesh Sharma sir, Director of ASBAS JSM COP College of Pharmacy, Bela, for his constant support, encouragement, and motivation in organizing this seminar. Sir, your guidance and your vision always inspired us to organize such meaningful academic programs. I would also like to thank all the faculty members, participants, and students who joined us today and contributed to making this session interactive and meaningful. At last but not the least, I extend my gratitude to the entire organizing team and technical staff whose behind the scene efforts ensured the successful conduct of this program. With this, I conclude the session and thank you all for being the part of this beautiful and wonderful seminar. Thank you so much, Rupal ma'am, for this enlightening session. It was wonderful listening you.
Thank you very much, ma'am. And there is a small announcement. The feedback form is shared on the WhatsApp group and also through the mail. And this link will be activated up to the 10 a.m. tomorrow. So please fill your feedback form as soon as possible. And certificates of this program is confirmed by 11 a.m. by tomorrow on the online attendance at YouTube and on the basis of the feedback. So thank you very much. Jai Hind and Jai Bharat.
Thank you, sir.
Thank you, sir.
for
Thank you
giving
so
us
much.
opportunity. Thank you.
Thank you, everyone, for sparing your valuable times. Thank you.